So I call upon my first speaker, Dr. GIRIRAJ.
Thank you, ma'am, for that kind introduction. Okay, so let me start with the first topic of this first session for today, vitreous hemorrhage and the normal fellow eye. So definition क्या है? Somebody might ask the PG students who might be seeing this recording. So definition क्या है? By definition, it is the presence of extravasated blood within a space which is lined posteriorly by the ILM, anteriorly by the posterior lens capsule, and laterally by the unpigmented epithelium of the ciliary body. So it can be either sub-ILM bleed, subhyaloid hemorrhage, or intragel hemorrhage. So in this beautiful article by Saxena and Dr. Subhadra Jalali et al., they classify vitreous hemorrhage based on its mechanisms. So some common mechanisms are retinal vascular disorders which cause ischemia, like ischemia leading to angiogenesis, which leads to vitreous hemorrhage. There are conditions of vascular anomalies where there is no ischemia, like rupture of a ram because of hypertension, bleed from an angioma, congenital arterial loops, etc. It can also be due to rupture of a normal vessel, as it happens in the retinal tears, in the retinal schisis, and PVD-induced vitreous hemorrhage and Valsalva retinopathy, etc. Another important cause in the old age people mainly is MNV or CNVM and peripheral exudative hemorrhagic chorioretinopathy and PCV being the most common amongst them. So just wanted to highlight the point, in pediatric age group, most common condition is trauma. I know Dr. Apurva is going to speak in detail on this, so this is just a list, I will not go into that. So diagnosis for a vitreous hemorrhage patient, you start thinking about the diagnosis as soon as the patient enters your OPD. The patient may be having a puffy face, you have to look at his gait, he may be debilitated or he may be obese, and he may be having a bandage to his foot, or there may be a central line poking out of his neck. He may be looking pale or he may be looking septic, for which he is being treated. So after that, definitely history is important, history of trauma. In rural population, and especially if you are taking history from women, you may have to take that in privacy because they may be afraid of telling the history of trauma in front of their relatives. Same thing applies to children also. They may be afraid to tell any history of fight in the school and all. Medical conditions, of course, most important, then history of any drug intake and history of previous surgeries. I want to highlight the point that after cataract surgery, if a patient is developing vitreous hemorrhage which was not there earlier, so you may have to think that if peribulbar anesthesia was given, there is possibility of globe rupture or needle perforation injury. So what is the checklist in case of VH? You have to look for any documented previous visual acuity, presence of RAPD for prognostication, and intraocular pressure. It may be low or it may be high. If it is low, you can suspect retinal detachment, or if it is high, you may have to look for neovascular glaucoma, etc. Look for neovascularization at the angles and at the iris. Lenticular opacities may help you in planning your management. Looking for lacrimal sac and adnexal evaluation, again, it is important. B-scan is the savior in total vitreous hemorrhage cases. You may find presence of retinal hemorrhage or intraocular foreign body or any other pathologies which may not be obviously seen. So examination of the fellow eye, again, it is very, very important. If on the 90D it may seem normal, but there might be something which is sneaking in the periphery. There might be in cases of trauma, there might be a small foreign body which might be missed in the other eye, or peripheral vasculitis can also be there, or a small peripheral tear will also be there. So indented examination of the other eye is a must. Coming to some of our cases, in this one point I wanted to highlight that in vitreous hemorrhage in a diabetic patient, there might be vitreous hemorrhage with TRD in one eye while the other might be normal. In this case, in the right eye, the patient has almost moderate to severe NPDR, and the left eye is completely normal, except for the pallor in the disc. So asymmetric DR, it is not so uncommon. It is seen in 5 to 10% of the patients with PDR. Again, in this beautiful article by Azad sir et al., they mention causes. Look at how carotid obstructive disease affects the progression of PDR. So if it is occurring before the onset of DR, it is protective. If it is occurring after the onset of DR, it is causing further increase in the ischemia and it leads to further progression of the DR. any inflammatory condition like uveitis, it is known to progress the diabetic changes, and degenerative changes like posterior vitreous detachment, chorioretinal atrophy, retinitis pigmentosa, etc. They are known to reduce the metabolic demand of the retina and therefore providing a protective effect against progression of PDR. So cataract surgery, of course, it will lead to breakdown of the blood retinal barrier, etc. Some of our cases, most common condition in hypertensives, we see branch retinal vein occlusion leading to vitreous hemorrhage. In cases of trauma, we have to look for GRTs or dialysis. In this, you can see the sutured cornea through which a wide field image has been taken. PCV, that is what breakthrough hemorrhage can cause. PCV can cause breakthrough hemorrhage, and of course vasculitis in young patients. So this condition, Dr. Guru sir is going to speak about it. I'll just leave this image for you, and sir will show operative surprise for this patient. So what we do in such cases, we send the patient to physician for evaluation. We follow protocol at our institute that all vitreous hemorrhage cases, we get peripheral smear with CBC counts done before posting for surgery. So to look out for any leukemic changes or any anemic changes or sickle cell, etc. So systemic evaluation, if it needs to be done, the physician will look into organomegaly and pulmonary hypertension, etc. What is the fate of vitreous hemorrhage? It can clear spontaneously, and or if it is there for the long time, it may lead to hemosidrosis or retinal toxicity, glial and fibrovascular proliferation, or ghost cell glaucoma, etc. Earlier, it was recommended that you can wait till 6 months also, but nowadays we decide the management depending on patient status, whether the patient is one-eyed, whether he needs his visual acuity for his work, or how long to wait based on the pathology itself. So after establishing the etiology, then the management observations can be either you can observe, you can do laser photocoagulation, or you can plan a pars plana vitrectomy. So in cases, observation, fresh vitreous hemorrhage often clears in days to weeks, and if you can see the retina through the vitreous hemorrhage, you can take a call based on that. If there is no presence of retinal detachment or an infection, you can wait for the vitreous hemorrhage to clear, and you should start PRP laser as soon as some part of the retina is visible to you. So role of vitamin C in or ascorbic acid in the patients of vitreous hemorrhage, again the role is not proven that it helps in absorption of vitreous hemorrhage, but its role has been proven in people who are having deficiency of vitamin C. Scurvy leading to vitreous hemorrhage is also reported, and role of vitamin C in prevention of macular ischemia has been reported. So PDR patients, there is no harm in giving vitamin C for prevention of macular ischemia. So laser, yes, of course, it is done, and even if you are suspecting PDR, it is always good to do an indented examination and look for associated retinal break or should tear. Vitrectomy common indications are non-resolving VH and patient needing early recovery, RD or presence of endophthalmitis. Again, vitrectomy in an open globe injury is a debatable topic. Some people say you can do it at the primary setting or you can do it later. Later helps in, there will be PVD, then the vitreous hemorrhage will be easy to clear, and you will have a firm globe also. So I think I'm in time. Thank you for this opportunity.